Okay, so I want to go ahead and introduce our speakers for this session from 11 to 12. I'm excited to have Laura Hale Brannan is here to talk with us. She's the project manager for dental therapy with the Dental Access Project at Community Catalyst. So prior to joining Community Catalyst, Laura worked for the Pew Charitable Trust, supporting state-based campaigns to authorize dental therapists. She also worked as a federal lobbyist for the American Society of Civil Engineers, covering transportation infrastructure policy. Laura holds a BA in political science from the University of Notre Dame. And then we also have Brett Weber. He serves as a public health policy and programs manager in the Public Health Policy and Programs Department at the National Indian Health Board. So prior to NIHB, Mr. Weber worked at the United States Senate Committee on Indian Affairs as a policy fellow, where he worked on health, environmental, energy, and other issues for then Vice Chairman John Tester, which is Vice Chairman John Tester. He has also worked as an intern at the White House Office of Public Engagement and Intergovernmental Affairs and the Louisiana Democratic Party. Mr. Weber completed his master's degree in public administration from the University of Georgia, and he holds a bachelor's degree in political science. And last but certainly not least, we've got Mr. Bruce Pratt. He's the policy analyst newly hired at the Southern Plains Tribal Health Board. Prior coming to SPTHB, he served as the president of the Pawnee Nation. While serving as the president, he was asked to serve on the HHS Secretary's Tribal Advisory Committee, Direct Service Tribes Advisory Committee, co-chairman of the National Budget Formulation for Indian Health Service, National Institute of Health Advisory Committee, Pawnee Service Unit Board, SPTH Board of Directors, as well as other Oklahoma tribal organizations. We're so glad to have all of you, all of our esteemed speakers and presenters today. So without further ado, I want to hand it over to Laura.
Awesome. Thank you so much. Good morning, all. I'm just going to go ahead and share my slides. So hold on with me for one moment. All right, that's showing up all right for everyone? Excellent. Okay, I'm also just going to warn folks, my internet's a little bit spotty, so if my voice starts cutting in and out, just like yell, wave or something, and I might have to turn my video off so you can continue hearing me, but we're gonna keep our fingers crossed that everything works all right for us. So good morning, all. As Julie said, I'm Laura Brannan. I'm the Dental Therapy Project Manager at Community Catalyst, and I'm going to talk to you about policy. So a little bit about who we are. So I work for Community Catalyst, which is a national nonprofit organization that works with state, community, and tribal organizations to increase community voice in healthcare decisions. And at Community Catalyst, we are co-chair of the National Partnership for Dental Therapy, which is a group that has come together to try to show the broad-based support for dental therapy and really increase its visibility, realizing that it is an evidence-based way to increase access to healthcare while also creating jobs and creating a more representative workforce. We're really excited to share our co-chairship with the National Coalition of Dentists for Health Equity and the National Indian Health Board. And my fellow co-chair Brett and I do this together a lot, and so he's going to do the second half of the presentation. I'm going to start us off with sort of broader context, and then Brett's going to take us into more specifics about how this works for tribes under the existing federal statutes. So if you find I'm a little high level, Brett will take it down a little more specific, but also please let us know if you have questions. So here are our learning objectives for today. We're trying to learn where dental therapists are practicing, where that's likely to expand, talk about the major policy issues as it relates to dental therapy. And to me, honestly, the third one is the most important, is learn what tribes and tribal organizations need to know to make sure their interests are being protected at both the state and the federal level. There's a lot of stuff moving on dental therapy right now in this country. Policies are really getting picked up at state levels and at national levels. And we really want to make sure that everyone is equipped to make sure their interests are being represented. There are enough other folks in this space who kind of will pick things up and run with them and shape them to their own interests. And so we want to make sure that the folks who originated dental therapy, which are tribal communities, are prepared to make sure their interests are really being represented as well. So a quick overview. I'm sure you guys mostly know this stuff, so I'm not going to go into too big of details about what is a dental therapist or any of that stuff, but if anyone wants me to do some of that stuff, I'm happy to as well. But quick recap, dental therapists have been working in the US for almost 20 years now, and they're authorized in at least 13 states in at least some settings. Add a little caveat that I'm not including Montana in that. I know Montana did authorize chat providers, which is awesome. They were forced to remove like all their restorative care from their dental therapist scope, so I'm not counting them, but I do know that that was in there. So I just wanted to add that caveat in case folks have questions. So dental therapists are currently working in 5 states, and that's going to be Alaska, Washington, Oregon, Minnesota, and Maine. There are 5 education programs operating, or I might be technically jumping the gun because the 5th program opens next month. And as I'm guessing Christina may have talked to you a little bit about earlier today, excitingly, the 5th education program that will open next month is a partnership between the Swinomish tribe and Skagit Valley College in Washington State, which is a really exciting new program. And they just received their accreditation last week. So tons of exciting news for dental therapy. And speaking of that accreditation, national education standards are in place for dental therapy. I get asked this a lot sometimes, folks feeling like, okay, this sounds interesting, but it sounds like all the states or tribes have to really do a lot of work to figure all this stuff out, makes them kind of anxious. There are education standards in place for dental therapy the same way there are for dentists and dental hygienists, and they come from the same entity. So there's the same national standard. So here we have just a little bit of an overview again of where I talked about where we have dental therapists currently, and the bluish states here are states that have had legislation to authorize dental therapists active in the last year and a half. So you can kind of see the way dental therapists are expanding. There has not been any legislation in Oklahoma that I'm aware of. There was legislation several years ago in Texas, and there has been legislation in Kansas for a number of years that I believe is currently being sort of championed by the Dental Hygiene Association there. So, you know, some of you may be from these states and may be seeing some of this activity. I should also say, you know, if you look out west from you guys, a lot of your Western neighbors out there in the neighborhood are all passing. So it is sort of a Western, there's like 3 real clusters. There's like a Western cluster, a Midwestern cluster, and then a Northeastern cluster. And then Florida's down there by itself, but that's Florida for you. So also, I just want to say, because some of you may be wondering about this, obviously, as sovereign governments, tribes have the right to employ dental therapists without any state authorization. I'm going to be talking primarily about state policy with y'all. And tribes have an absolute right to employ dental therapists without state authorization, and the Swinomish tribe actually did that. However, due to a nasty little restriction in the Indian Healthcare Improvement Act, which Brett's going to talk a lot more about, current federal law says that tribes are not allowed to use any federal money for dental therapist services unless the state authorizes dental therapists. So that means currently for most tribes for whom it would not be financially feasible to hire a dental therapist and not use any of that federal money, they do have to engage with the state process. And I would also say, and we're going to talk about a little bit more in a minute, even if the Indian Healthcare Improvement Act is amended, which we're all really hoping will and trying to make that happen, I think the state policy is still kind of matters for tribes, trying to ensure maximum options for education and for the individual providers. So I'm going to talk about 4 key policy issues, which are education, scope. Scope, for anyone who's not a clinical person, is just like the set of procedures you're allowed to do as a specific kind of provider. Supervision, settings, which I'm using to mean kind of where they're allowed to work. And I just want to say that like these details are really important. I sometimes have folks say to me like, oh, there's a dental therapy bill introduced in my state. Like, I'm really excited. I know dental therapy is really great. And I'm like, oh, it's awesome. And so I'm asked, some details. And they're like, oh, I don't really know the details, but I'm sure it's great. The problem is the details really, really matter on this, because they are the difference between a policy that really improves health equity, that creates a representative workforce, that really allows tribes to have the same opportunity that the folks in the Pacific Northwest and in Alaska have had, or one that is really just sort of reinforcing the status quo and keeping pretty much all those educational barriers in place. So the details on this, unfortunately, really matter. So the first big one, education. So like I mentioned, there are national education standards for dental therapy. The Commission on Dental Accreditation, which is actually part of the American Dental Association, although it's sort of semi-autonomous, sets standards for dental education in the US. They have a special permission, special authorization from the US Department of Education for this. They are like the one entity in the US that does this for dental education. And they adopted education standards for dental therapy in 2015, which was a really big deal because it meant that they recognized that dental therapy was here to stay, that it was safe, that it was effective, and that you could provide high quality education to dental therapists. So it was a really big deal. I should also say they didn't do that out of the goodness of their own hearts. They did that after a lot of pressure from a lot of advocates and from a lot of tribal leaders, who were really sort of pushing them to do the right thing and to think about public health and not just the dental profession. So the standards require a minimum of 3 academic years of instruction. I want to be clear about that academic word. Some folks may be familiar with the education program in Alaska or the new one opening in Washington State, and they're 2-year programs. And you might say, how does that work? Well, the difference is in academia, everyone takes the summer off, and those education programs don't. So they put 3 academic years into 2 calendar years, which you're allowed to do. And so the standards also leave any prerequisites or specific degree requirements up to the state. And this is important because some states have been adding extra requirements. And the most common one is requiring that dental therapists also be dental hygienists. Although sometimes also there'll be a requirement that a dental therapist have a bachelor's or a master's degree. And the reason this is problematic is that, ultimately, we know the more education you require of someone, basically, the harder it is going to be to get. The more expensive, the longer the program, and the fewer schools are going to be able to offer it. A lot fewer kinds of colleges in the US can offer a bachelor's degree, and even fewer can offer a master's degree. So if you think about frequently your community colleges, most of them are not allowed to offer anything outside of an associate's degree. And those are going to be the schools that are frequently most likely to be in areas where folks have access problems, or focusing on educating students from communities with access problems. That's really important. And I also want to say dental hygienists make awesome dental therapists. Dental hygienists have been doing dental therapy for a long time. And there are several education programs that are set up specifically to give advanced standing for existing dental hygienists, which means the program is a bit shorter, which is awesome, and we should totally do that. We should allow more career laddering, I would say, in the dental professions generally, but you don't have to be a dental hygienist to be a dental therapist. The scopes are actually distinct. They have overlap, but they're also distinct. And so I just really want to be clear about that, because we absolutely love our dental hygienists. We really need them. Dental therapists are not a replacement for them. But it's also problematic to require that they be both. It adds a lot more time and a lot more cost to the education. So scope, like I mentioned, this is going to be your set of procedures a dental therapist can do. The Code of Standards is education standards set a minimum scope that a dental therapist has to be educated in. But states are allowed, or tribes are allowed, to add more procedures to the scope as long as the dental therapists are educated in them as well, of course. So the CHAP standards in most states allow dental therapists to perform exams and to create treatment plans. And this is really important. I think they should be in the Code of Standards. That was really controversial, and they're not. But basically, every state allows it. And so this is going to be one of those really, really important things, because if a dental therapist can't do an exam and create a treatment plan without a dentist standing right next to him and also examining the patient, all of a sudden that person can't work anywhere where they don't already have a dentist. And you know, a lot of the point of this is to be able to get care to where dentists aren't. So that's a really important piece. The other big thing that is not in the code of standards that dental therapists are generally allowed to do is permanent extractions. They're your adult teeth. But it's under really limited circumstances, but how limited of circumstances varies. I think the CHAP standards have the broadest definition, and even that is pretty limited. And then other states have it so narrow that it's basically only like a tooth that's like so wobbly. You don't need any actual tools. You can just remove it with a piece of gauze. So if you think about like a little kid's tooth that's that wobbly, if you had an adult tooth that was that wobbly, which really only happens after like extensive like bone loss, usually in the elderly. And so I should also say, like I mentioned, dental therapists can perform many, but not all of the procedures hygienists can do. But there's also a different focus. So while a dentist is also trained in, you know, the same procedures a dental therapist and a dental hygienist are trained in, they spend most of their time in school focusing on the more complicated procedures because that's the stuff they really got to know. So it's the same thing. The way, you know, a dental therapist may learn how to clean teeth, they're going to learn that in a not very long period of time, whereas a hygienist is going to spend a lot longer learning that piece. And that's because that's kind of the bread and butter of what a lot of hygienists are doing. And that time is really spent developing those hand skills. So I'm not saying a dental therapist can't scale your teeth. They technically can. They can do it. But most of the time, you're still going to have your hygienist doing it, unless it's a setting where for some reason there's not a hygienist there that day. So I just want to be clear about this. This is something that took me a long time to understand because I'm not a provider and I don't have a job that I have to think about spending time developing hand skills. But dental therapists focus most of their education on doing restoration. So that's filling cavities, because those are the hand skills they really need to develop. So supervision. Dental therapists always work under the supervision of a dentist. In no state or under the CHAP standards are they independent. I don't think they're currently ready to be. I'm not sure if that would even ever be the case. Like dental therapists are trained in the US to work under the supervision of dentists. And when I say supervision, that doesn't mean a dentist is standing right over their shoulder. There's a lot of different kinds of supervision, generally in medicine and dentistry. There's one called general supervision, which means your dentist doesn't need to be on site and they don't need to see the patient first. That is what dental therapists are generally allowed to work under most states. And dental therapists are going to be most effective when they have this flexibility. One of the nice things is pretty much every state requires the dental therapist work under a practice agreement. It's kind of like standing orders if you're familiar with how nurse practitioners or physician assistants work at all. It's kind of a series of protocols that they've agreed to with their supervising dentist, and that's going to include supervision for a dental therapist, and that can change over time. So when a dental therapist is brand new, you know, they may be working under stricter supervision, but eventually the dentist is going to say, actually, you know what, I'm comfortable with you going to another town or working at the clinic on days I'm not here, things like that. And I will say CHAP standards and most states do require a period of time where the dental therapist is working on site with their supervising dentist for a certain period of time before they're going off site. And that's really helping build that relationship, help the dentist understand what the dental therapist's strengths and weaknesses are, help the dental therapist really establish that rapport and their trusting relationship with their dentist. So most places do require that. It's anywhere from like 400 to 2,000 hours. It usually takes about a year. Kind of depends how you count it. Some folks count all the time you're working, and some folks only count the time you're doing clinical procedures, but generally it takes about a year. And settings. So where dental therapists are allowed to work really varies by state. So there are 3 states where dental therapists are only allowed within the tribal health system. So those are going to be Alaska, Idaho, and Washington. Alaska, they only work under federal authority because they were, you know, where CHAP began. And so they were not affected by the restriction in the Indian Healthcare Improvement Act when it nationalized CHAP, and Brett will talk about that. But Idaho and Washington, dental therapists can work in tribal communities, and they did both have to pass state laws so they could access those federal funds to pay for dental therapist services. We've got several other states, Arizona, Connecticut, New Mexico, and Nevada, where dental therapists can only work in public health settings or tribal settings. But then there's also some states where you can work in any setting, but most of your patients have to somehow be underserved, which is generally like on Medicaid, uninsured, possessing a disability that makes it harder to get dental care, or if you live in a dental shortage area, that's frequently satisfies the requirement as well. And I know a lot of our country are dental shortage areas. We have about 60 million people in this country who live in shortage areas. So honestly, that accounts for pretty much most of the country geographically. I know in the state of Minnesota, which was the first state to actually pass a state law authorizing dental therapy, I think the entire state, apart from the Twin Cities, is a dental shortage area. And then we've got 3 states where dental therapists can work anywhere. And honestly, I think that this is going to be ultimately the trend, because we don't restrict where dentists work. We don't restrict where hygienists work. You know, we don't say doctors and nurse practitioners can only work in public health settings. If you are a provider who meets the standards of your profession, you've been well educated, you know, you generally can work wherever you want. And we've got a lot of sort of incentive programs and whatnot to try to focus those people in certain settings. So I think, you know, in the short term, we're seeing a lot of folks really trying to help make sure dental therapists are going to public health settings, because the point of authorizing them is to, you know, be improving public health. But I would say ultimately, if I had to guess 50 years from now, dental therapists will be able to work in any setting a dentist or a hygienist could. And then, I'm not sure how I'm doing on time, so just Julie, yell at me if I need to shut up. But I've got a couple of lessons learned I want to talk about. So 3 sort of big ones to keep in mind as you might be looking at legislation. If legislation comes in your state, you know, whether you want to be involved from the beginning or whether something kind of shows up in your state and folks reach out to you and say, hey, what do you guys think about this? 3 lessons learned to keep in mind from other states. One, you want to make sure that there's a pathway in the legislation for existing providers. And what that means is, because we have those code of standards, which is awesome, so happy about that, a lot of folks are just writing their statutes saying, to be a dental therapist, you have to graduate from an education program that is accredited by CODA. Now, that's the same way we write statutes for hygienists and for dentists, which makes sense. Graduate from a CODA accredited program. Cool. The problem is, as we're kind of really in the early stages of this a little bit, there are a lot of people who graduated from programs prior to CODA, because there were 3 education programs already going before the CODA standards are created. And then after they were created, it takes some time to get your application ready and to apply and to receive. Like, schools all had at least a 2-year delay because of COVID. So what this means is that we've got close to 200 dental therapists working in the US right now. Almost all of them, like less than 10 of them, graduated from programs that were CODA accredited at the time they graduated. So that means that most of those dental therapists are not able to work in any state that is requiring CODA accreditation, even though some of them have been working for almost 20 years. They wouldn't be able to work in a state that requires graduation from CODA accreditation. I know this has been a problem in several states, including, I know in Idaho, their law requires graduation from a CODA accredited program. Anyone who completed the Alaska Dental Therapy Education Program basically prior to like August 2020 is suddenly not eligible. So it's a big problem. And because, you know, generally you want your providers to be able to move. And so right now that means that you know, there's a lot less flexibility for providers, and it makes it a lot harder for tribes or for anyone else to hire a therapist who is educated and has been working for a few years. So the next lesson is tribal carve out. So this really is sort of focused mostly on Arizona and New Mexico. So like I talked about earlier, you know, there are sometimes efforts to insert extra educational requirements into legislation, and those tend to be either requiring dental therapists also be dental hygienists or requiring that they hold master's degrees. And, you know, the tribes in pretty much every state have come out really strongly against these requirements. They run completely counter to the way dental therapy was created in CHAP, and they're really exclusionary. You can take an education program that could be completed in like 2 calendar years, and all of a sudden it's a lot longer and a lot more expensive. So this is a major area of concern. In both Arizona and New Mexico, the tribes were working really hard to make sure that the education standards didn't require extra degrees, didn't require prerequisites, but ultimately the legislation in both of those states went that way. And so I think the policymakers in each state basically said, like, well, as to have like a tiny bit of something for the tribes, we're just going to give a little carve out. We're going to say, okay, well, you have to be a hygienist if you're working in Arizona or New Mexico, but not if you're working in a tribal community, which I think was their feeling, like, well, we satisfied everyone. But they didn't really, because this is really hard. The schools that have been interested, there are 2 tribal colleges that were interested in creating dental therapy education programs, but both of them are really concerned about creating an education program, that is going to take their students several years. It's a lot of their time, and they would only be allowed to work in the tribal health system. If they wanted to, work in a different clinic in their same state, they wouldn't be able to do that. And, potential dental therapists have that same concern. It does create a feeling of sort of 2 tiers of care. Even though we know that, dental therapists don't need to be hygienists or have master's degrees to be perfectly competent, high quality providers. And so these sorts of requirements, which are one requirement for tribes, one requirement for everyone else, really aren't good, because what it means is that sort of the statewide standard frequently just becomes the standard. And I would say what we talk a lot about is, if we create policies that don't have extra requirements, say, okay, an education program needs to be CODA accredited, but we also need a pathway for students who graduated prior to CODA, but mostly just a program should be CODA accredited. We're not going to put extra education requirements in the law. That's really leaving flexibility for schools, for employers, and for students. So schools are going to be able to figure out what is the right dental therapy program for their community. And that may be an associate's degree program that puts 3 academic years into 2 calendar years. Or it may be in a state where they have a huge number of hygienists. There are states with surpluses of hygienists, and their hygienists are trying to figure out what they can do to actually, find jobs and to like really help. And so they may realize, what, if we created a program that offers advanced standing for hygienists, that's actually going to be what we really want. And if we basically leave it up to schools by not requiring extra degrees or extra prereqs, all of a sudden people have the flexibility to figure out what the program is right for their community. And just the same for employers. Some employers may prefer duly trained providers. They also tend to be more expensive. So for some clinics, that may not make sense. In some clinics, you may actually really use both your hygiene scope and your dental therapy scope. But in other clinics, they may say, actually, we have hygienists. We just want you doing your therapy scope. It doesn't really make sense to pay extra for someone who's duly trained. And then exactly the same for students. Some students may want to be able to get both sets of training, but not others. And so we should kind of leave it up for folks to make that decision for themselves, as opposed to putting this requirement in statute. And finally, we'll talk about kind of unified efforts. So I should say I've been working on dental therapy for 7-ish years. I've worked in, at least 15 states, I think. What I have seen is the strongest dental therapy policies are developed when the folks who are really doing this from a perspective of community health, of health equity, of creating a representative workforce are involved at the beginning. And that sort of ethos is baked in from the beginning. And this is how dental therapy began in Alaska, right? It was a community-based solution. It was a tribally led solution, figuring out how can our communities help themselves. And so you can also add a lot of these restrictions, though, like we talked about, and all of a sudden dental therapy starts to look kind of like something different. So what I've generally seen is you get the strongest policies when the folks that really want to see these sorts of strong programs created are involved from the very beginning. And frequently in states that have tribes, that also means a strong tribal involvement. I would say Washington and Oregon are 2 great examples where I know the tribes have been involved really from the very beginning. They were sort of major stakeholders in the statewide campaigns. Really, they led the Oregon campaign. And they created really strong, basically, relationships with non-tribal stakeholders to make sure that they passed laws, and they created policies in those states that would work for tribal communities and not non-tribal communities alike. And I should also just finally say, sometimes I think folks get this idea that like, well, the tribal communities really care about accessibility and things like that, and the non-tribal communities don't. It is absolutely not just tribal communities where people, have longstanding issues accessing care, and folks feel like their dentists are outsiders who don't stay long and who don't understand their language or understand their culture. I work with communities all over the country, in California, in Florida, all over, who have the same experience, generally communities of color, who say, look, we want that ability too. We want to be able to create a program so that we are creating a more representative dental workforce, that we are creating good paying jobs for our community members, and that we're changing the idea of what oral health looks like and what an oral health provider looks like. So this is something that I think actually a lot of folks can really, really get excited about, because this is not a problem unique to tribal communities, although this is a solution that came out of tribal communities and has amazing tribal leadership. But a lot of other communities in the US are really excited to be following the example of tribes. And finally, just a key resource is the National Model Act. It was created in 2019 by a big group of dental therapy experts, and it is a very detailed breakdown of policy issues and has sample legislative language. If you want to learn more about dental therapy policy, I encourage you to check it out. If you get to a point where people start talking about maybe doing dental therapy in your state, it's a great first resource. Also, because I'm assuming you're not going to remember everything I just said extremely quickly at you. So that is everything from me, and I will hand it over to Pratt.
Sure, thank you so much, Laura. Now I'm going to go ahead and, Julie, can you enable screen sharing for me?
Yes, let me do that here.
Sure, and if you have a question from Laura's presentation, definitely jot it down or something, because we're going to have a good question and answer session after we're done. Because I've been working on dental therapy for 6 years. Laura's been working on it for 7 or 8 years, and we both still have questions about this model ourselves. So if there's something that is a little confusing or doesn't make sense, we're happy to talk about it a bit.
Try now, Brett.
Okay, and I'm going to hit okay. Can someone give me a thumbs up if my slides are showing? Okay, wonderful, wonderful. Okay, so like I said at the beginning, I'm Brett Weber. I'm a public health policy and programs manager at the National Indian Health Board. If you've never heard of National Indian Health Board, today is your lucky day. We were founded by the tribes in 1972 to serve as the tribal advocate for healthcare. So this is our 50th anniversary. Wish us a happy birthday, please, on Twitter. We are based in Washington, D.C., and our board of directors includes a tribal leader from each service area elected to be that area's representative. From the Oklahoma City area with the Southern Plains, it's Marty Wofford, who's also the chairwoman of Southern Plains Tribal Health Board. This is a little bit of an org chart about how we work. Don't stress about it, because it does look a little complicated. We serve and advocate for all 574 federally recognized tribal governments in the area of health. We work with the 11 area Indian health boards, including, of course, Southern Plains, and they each send a member to our board, as I mentioned. And we work with tribal advisory groups, stakeholders and advocates, and other external partners to advocate to the federal government across all 3 branches. So a little bit about our oral health initiative. Our board of directors passed a resolution in support of the dental health aid therapy program in Alaska. And you'll see DHAT and dental therapist, they're the same thing. A DHAT just works within the Indian health system, but they're synonymous otherwise. In 2017, we created our oral health initiative to provide assessments of tribal oral health workforces, dental therapy trainings, state legislative monitoring, and national advocacy. And as Laura mentioned, in 2018, we joined with non-tribal dental therapy leaders such as Community Catalyst and the Coalition of Dentists for Health Equity to co-chair the National Partnership for Dental Therapy. And that website is just dentaltherapy.org, where the partnership has put together quite a bit of useful resources. So as Laura mentioned, I'm going to do a little bit of a not quite deep dive, but we're going to wade into the waters a little bit around how tribes can have dental therapy working in their communities. There are 3 routes. One is the Swinomish route, which is a wonderful exercise in sovereignty. And you can see this picture. The Swinomish tribe in Washington state created a licensing board so that providers could be licensed to practice on Swinomish land. This model has been replicated by another tribe in Washington state and is a really interesting form of sovereignty because Swinomish as a sovereign tribal nation has the authority and the ability to determine who practices on their lands. They did have to have a pretty good relationship with Washington state to ensure that that licensure was respected by the state health reimbursement agency so that Medicaid dollars could flow in based on the services those providers offered. But this is a really interesting route that NIHB is working on creating more resources around if tribes are interested in this. The second route is state licensure, and that is particular to self-governance tribes that would hire, physicians or nurse practitioners or any other provider that has a state license, or the state of Oklahoma or the state of Kansas, the state of Texas offers a license, and that's the person's credentials. No tribe has gone this route of hiring a dental therapist purely through state licensure, so I don't have a lot to say here. Maybe I will in a couple of years if a tribe tests this out. But the third way, and the way that I'm going to talk quite a bit about, and if you were in Christina Peters' presentation, she talked about, is employing federally certified dental therapists through the CHAP program, and CHAP stands for Community Health Aid Program. And I'm going to talk about how the Indian Healthcare Improvement Act interacts with that in a second. So the Community Health Aid Program is funded by IHS, and it's operated through the Alaska Native Tribal Health Consortium, so it's specific to Alaska right now. Don't worry about memorizing every date on this timeline. I promise there's no quiz at the end. Just keep in mind, CHAP has been around for decades, right? We're coming up on over 60 years. And it's a successful program that offers frontline medical, behavioral, and dental health services to Alaska Native communities. I do want to point out that 2005 date when dental health aides were certified and began practicing in Alaska Native communities. So dental therapists have been in America and in Alaska Native communities for coming up on 20 years. So there's a pretty good record of success there. So Congress gave IHS the authority to expand CHAP to tribes outside of Alaska. And again, I'll talk about that restriction in a second. They did that in 2010. And IHS went through a consultation process and elected to begin the expansion of CHAP to tribes outside of Alaska in 2016. The IHS and CHAP Tribal Advisory Group, or CHAP-TAG, drafted an interim policy over the course of 2 years, and finally published a position description for dental therapists that is required for all federal positions. So this is something that would benefit the direct service tribes. This is something that they would need to be able to have dental therapists working in their facilities. It is used again for IHS facilities and direct service tribes. It can be copied by the tribes or copied and tweaked or something like that. I do want to stress COVID-19 really slowed down the expansion work, but the policy is in place and has been in place for about coming up on 2 years, and the areas can begin establishing CHAP infrastructure. I do want to just get a couple of the things out of the way. Progress, again, has been very slow. Remember, like, I'm going to go back. It began this process in 2016. It's 2022 and it's not done yet. Congress is allocating only $5 million per year, and that estimated need is closer to $60 million per year. So to get CHAP up and running, there needs to be a significant investment from the federal government. I am happy to say that in draft appropriations on the House of Representatives side, Congress is planning to allocate $20 million, a $20 million increase to CHAP for this coming year, but that's just a draft. The appropriations process is still ongoing, so I don't have a final number for you, but we are happy to see that Congress is at least considering a substantial increase. So the things that the areas will need to consider as they build up CHAP infrastructure are the certification boards. And there's going to be a national certification board across the entire nation, and each area will also have its certification board. If an area says, we don't really have a desire to have an area certification board, or we frankly don't have the capacity or a sufficient level of expertise to create and dedicate an area certification board, there can be reciprocity agreements. Alaska's board has been around for decades. Maybe we'll just say, okay, we'll have a reciprocity agreement with Alaska. If you're certified by Alaska, you're certified to work in our area too. And there's also academic review committees that provide recommendations to the security board, certification board on the scope of CHAP providers. So if there's new research saying that a new procedure is something that a dental therapist is trained to do, then that's something that can be added to their scope. That's a pretty laborious process, and we're not getting that far in the weeds today. So I don't have much more to say there. But all this to say, CHAP is a wonderful, successful program that it's my hope that tribes implement. The benefits are that the provision of routine, preventative, and emergent care in rural communities that the Western healthcare model really struggles to meet. And certainly in Alaska Native communities, we see that where, these villages have 200-300 people. That's not enough to sustain a full-time dentist. So a dentist would come, fly in once a year, stay a week, and that was the care that they got. But the dental therapists are really changing that model by being more flexible and being able to see, take care of less complicated cases earlier and keeping those cases from developing into more severe cases. One thing that Christina probably touched upon was that CHAP providers tend to come from the communities they serve. So a lot of CHAP providers in Alaska, the overwhelming majority of them are Alaska Native. And having that cultural competency provides an understanding and a shared history, culture, and language. And sometimes it means that literally, if a person doesn't speak English, the dental therapist can communicate in their native language. And that's something that, a lot of other healthcare models don't have the benefit of. And having that kind of patient to provider trust and shared background really puts the patient at ease and makes them more likely to seek care. There's continuity of care in communities that face recruitment and retention challenges. If you work in a tribal health setting, I don't want to speak to your experience, but if you are struggling with recruitment and retention, you're in pretty good company. That's people get burnt out, they want to do something else. And that's something that the tribal health systems across the country have to counter. And then also cost savings for tribes and individuals receiving care outside of the IHS system, because more of those services are being able to happen in-house instead of being referred out. So CHAP is a wonderful program, and the slowness of the expansion aside, I don't want anyone to feel too jaded here, because it is a good thing, and I'm hopeful that that expansion is going to be successful. So let's talk about the Indian Healthcare Improvement Act. It is a seminal law, and it gives IHS authorities to provide additional services beyond basic medical services. It first passed in the 70s and was needed to be reauthorized every 5 or so years. And at one point, the National Indian Health Board was essentially the body that saw IKEA get reauthorized through Congress. That was our big thing. But we don't have to do that anymore, because IKEA was permanently reauthorized in 2010 as part of the Affordable Care Act. And that is the law, as I mentioned, that gave IHS the authority to expand CHAP to tribes outside of Alaska. But there's a big old but here. Tribes cannot use DHATs, the dental therapists, under CHAP unless the state gives them permission. This is an extremely problematic dynamic. It was an amendment that was kind of attached to the bill at the 11th hour after, the Affordable Care Act was too late to change. And, if you're looking on a small screen, this text might be a little bit hard to read, but I did upload my slides, so you're free to download them and follow along at your own pace. This section B, this highlighted section, as IHS is expanding CHAP nationwide, the expansion shall exclude dental health aid therapy services from services covered under the program, right? So you can't do dental therapy. You can do those medical services, you can do those behavioral services, but no dental therapy. But look at this paragraph underneath it. So it's saying basically you can do dental therapy if your state gives you permission, and supplies such services in accordance with state law. This is a weird and problematic provision because the federal trust and treaty responsibility is inherent to the federal government, and it provides a relationship between the federal government and the tribes. The states don't really fit in there. So if a tribe says, hey, we want to hire another physician or something, or we want our nutritionist to receive some training to provide another scope of services, the state can't come in and say, no, tribe, you can't do that, right? Because that would be an inappropriate use of state power. It would be an inappropriate infringement on tribal sovereignty, and it would be a gross misunderstanding of the trust and treaty responsibility. So it is weird and troubling that Congress gave states the ability to intervene here. And that's why National Indian Health Board and many other tribal organizations, including Southern Plains, have worked with state partners and non-tribal partners, both to fix this law and also to increase the number of states that are licensing dental therapists. Because once a state licensed dental therapists, then okay, your state has given your permission. So we do have a fact sheet that we are giving to members of Congress whenever we meet with them. Again, we are based in Washington, D.C., and we do work with Congress very frequently. This fact sheet is on our website. Don't worry about reading it, but you can download it off of our website. I also emailed it to Julie. So Julie, I don't want to put you on the spot, but if you're able to email that out to the registrants or the attendees, that would be awesome. And if not, you can find it on NIHB's website. Another thing I want to really plug is that in the next couple of weeks, we at NIHB are going to be putting out a student sponsorship opportunity, excuse me. And this sponsorship opportunity supports up to 6 tribes and tribal organizations that are sponsoring dental therapy students with $10,000 grant awards. That $10,000 is to support tuition and living expenses for the sponsored student. And typically what will happen at the 2 CODA accredited programs in Alaska and now at Skagit Valley in Washington State, a tribe or, in Alaska, the Tribal Health Consortia will sponsor a student and say, okay, we'll pay your tuition, but once you graduate, come work for us for 2 or sometimes 4 years. But that tribe or the sponsoring entity has to eat the tuition cost up front. And then, so this student sponsorship fund kind of makes that a little less burdensome on the tribe. So we call it a student sponsorship because it doesn't go to the student, it goes to the tribe. And then the tribe can either, use that for tuition or give money to the student to support their living expenses. The rule is that they must be enrolled in an accredited dental therapy education program for the upcoming school year. And we are going to put this funding opportunity out in the next couple of weeks. So please be on the lookout. And if your tribe is thinking of sponsoring a dental therapy student, we are going to have this opportunity next year as well. So I hope that you'll give this a good long look. I do just want to reiterate a few things Laura said when she's talking about components in dental therapy legislation. The details really do matter for tribes. Especially since we're having to deal with state governments to get this, permission. Each state's legislative process is going to be unique. The dental therapy laws vary from state to state. And that model act that was developed over the course of a few years by a panel of dental therapy experts really is something that would very much benefit Indian country if all 50 states kind of implemented that model act. That would be a way that is, really good for Indian country because it follows the CODA standards for a scope of practice. So there's uniformity, and the education programs can kind of have one curriculum that speaks to that that speaks to those standards for a scope. And then also what we see in tribal communities is that when there is no bachelor's or master's degree requirement and no hygiene requirement, that's when dental therapy becomes most accessible for tribes. Again, like Laura said, I love dental hygienists. I am pro dental hygienist. I use dental hygienists twice a year, so we want them to feel respected and everything. And we're certainly not anti-hygienists, but they are a separate profession. And if you as a state lawmaker mandate that these two professions overlap, that kind of, rubs people the wrong way, and it makes both models a little less effective. So, if a dental hygienist wants to become a dental therapist and have a dual role, awesome, fantastic. They can go to school and do that. Don't put that in statute. Don't make everyone do that. Leave it up to a personal choice or, an arrangement between that dental hygienist and the dentist they work for. And we are at NIHP going to be creating some fact sheets that show why these different legislative components are important to Indian country, and we'll have some public health data. I'm hoping to debut those by the end of the calendar year, but we will see. Lastly, I think this is lastly, we did create a dental therapy startup guide for tribal leaders. It's not only for tribal leaders, but it is, it's kind of targeted towards that audience to make this complex issue more digestible and include concrete action steps. So if you're interested in getting started on dental therapy at the tribal level, that's, something to read and maybe bring up with your tribal leadership. And that is it from me. So I'm going to stop sharing, and I said I'm going to stop sharing. There we go. And I think I'll turn it over to Mr. Bruce Pratt.
Yeah, I thank you so much, Brett and Laura. And I'm going to kind of segue into kind of our last 5 minutes of the session with just some closing thoughts from Bruce through kind of an Oklahoma area lens. Before I do that, I just want to remind everyone to fill out the evaluations and join us for the next 2 sessions as well. I know we're not really going to have time to get to any Q&A today, but bring your questions, bring your stories, your reflection about in relation to CHAP, to the tribal healthcare workforce, to our listening session, where it's going to be kind of an informal discussion and we can answer some questions. And so if you didn't get an opportunity in the first 2 sessions, in our next one, which is kind of some research surrounding different providers, bring those to the listening session. That'll be at 2 o'clock today. And so just some closing thoughts for you, Bruce. So as the policy analyst for the Southern Plains Tribal Health Board, which represents tribes in Oklahoma, Kansas, and Texas, and with your policy experience, how do you envision CHAP implementation, which we know there's a lot to that, kind of based on Christina's session and Brett and Laura. And then also like the advocacy efforts for dental therapy what we understand in the broader scope of things has to be approved by the state at this point, and probably to come. What does that look like, and how can we best prepare to support our tribes and our tribal communities in this effort?
Well, I'm thankful for the presentation, Brett and Laura, and getting to hear the things that you presented. When I served on the STAC committee at the national level, all of these things were brought forward, was actually able to go to the western side of the United States and look at a CHAP program. And it is something that is really needed in all of Indian country. And that's the main part is we do have the need. We have the need. I think a lot of folks maybe don't understand and that we have to use our voices, to get this need looked at, especially at the state level here in Oklahoma. And we don't have sometimes a very good relationship with the state of Oklahoma in things that deals with the tribal anything right now. But there's always hope. And so we need to use our voices. We need to work with the state leaders, our state liaisons there in the state of Oklahoma on all these health issues. Tribes need to know that these things work. All the Oklahoma tribes need to know that these things work. There's careers in them. There's more of a real benefit to all of our Indian people. Right now, one of the hardest things to do is for a adult male and adult female Indians, natives, to get into and get your teeth worked on. Here in Oklahoma, that's one of the hardest things. It's like finding the best thing ever, and I'm one because I can do that. I'm a diabetic, so I can get in. I have a privilege there, but like my wife, hard for her to get in. And so I understand that that's a real hardship for our Indian people. And if we could ever get this dental therapy program with the therapists here in Oklahoma, that would just be such a blessing, you know, to our people and the benefit to all of our people. And so that's the main thing, is just we got to use our voice. We got to show and be able to have our tribal leaders to use their voices and see if we can get something done here in Oklahoma. It's a big ask at times, but it's something that is, the benefit outweighs everything, and so it needs to be done. So we all need to use our voices and whatever we can to make it happen. So I'll say all that and turn it back over to Julie.
Thank you so much, Bruce. And thank you, Brett, and thank you, Laura. Again, I just put in the chat, join us. We're at time, we're at noon Central Time. So join us at 1 p.m. for a third session in the series. And then again at 2 o'clock for our listening session, where we want to hear from you all. So come back and join us and enjoy the hour break. Thank you so much. Appreciate it. Don't forget your evaluations. Bye, everyone.